I'm Julie Muller, Education Chair of this meeting today. Welcome one and all to our second Protect and Elect Educational Forum. Some of you were lucky enough to attend our first forum on another hot topic, gerrymandering. Now we are commencing our second concerning the compelling conundrum of healthcare in America, what now? Barry Friedman, President and CEO of Einstein Healthcare Network, our co-chair for this huge undertaking, is not available to be with us due to a loss of a dear friend. He helped organize this outstanding panel and reached out to his right-hand COO at Einstein, Ruth Lefton, to fill in as our esteemed moderator. We all send Merrill, his wife, also an enthusiastic member of our committee, our heartfelt condolences. Protect and Elect was started a few months ago by a dozen women committed to elect candidates who reflect democratic values and are committed to the protection and preservation of individual rights. Will our steering committee please stand? Thank you, sir. We formed a group to provide information and advise members regarding candidates we support at all state, federal, and municipal levels. We could not be more fortunate. Our moderator and panel are the creme de la creme of regional health care. They have accepted our challenge of helping us wade through today's healthcare maze and make some sense of the current situation. Phyllis Fisher will now introduce our moderator, Ruth Lefton.
Thanks, Julie. And we are also handing out 3x5 cards and pencils if anyone has questions they would like addressed.
It's my pleasure to introduce to you Ruth Lefton. Ruth is the Chief Operating Officer for Albert Einstein Healthcare Network, overseeing not only Einstein Medical Center, Philadelphia, but Einstein Medical Center, Elkins Park, Moss Rehab, and Willowcrest. She's been in this position for the past 16 months. Prior to this, she was Chief Operating Officer for Moss Rehab for 14 years, where she oversaw the significant growth of Moss Rehab to 6 inpatient and 14 outpatient locations. Ms. Lefton has a B.S. in finance from the Rochester Institute of Technology and an MHSA from the University of Michigan. Please join me in welcoming Ruth Lefton.
Thank you, and I hope there are no Penn State graduates in here who are going to rub it in about the football game last weekend. It's my pleasure to be here to be your moderator to fill the large shoes of Barry Friedman. So I'm going to make a few remarks before we get into our panel discussion. If you're like me, it's been hard to keep up with the status of the Medicare program, the numerous attempts to repeal and replace the Affordable Care Act, the status of the cost-sharing reduction reimbursements to insurance companies. Just today, there's more information coming out about that, how it might affect the mandates, or the effects that tax reform, if passed, may have on Medicare, just to name a few of the issues. And this uncertainty has many of us concerned as to whether health care will be available and affordable for all of us and our children and our grandchildren in the future. So we have a great lineup today who are going to explore these issues. Our panelists represent a range of stakeholders within the healthcare spectrum: payers, providers, physicians, policymakers, and community interests. You'll hear how these different groups feel we're adapting to the changes in the healthcare system and where healthcare is headed. At the end, we're going to have questions and answers, and someone mentioned there are index cards that you can write your questions on, and we'll direct them to the appropriate people. Before we get into that panel discussion, I'm going to just spend a few moments providing an overview of the healthcare landscape. Well, healthcare in the United States is in the midst of an unprecedented period of uncertain transition. Change a long time in coming as our system continues to spiral toward unsustainability. And I'm going to show my age, but when I was in graduate school in the mid-'80s, healthcare expenditures were about 10% of the gross domestic product, and we called that unsustainable. Well, right now, healthcare expenditures are about 18% of GDP, with between $9,000 and $10,000 spending per capita per year. And we baby boomers in this room, we're only going to be adding to that figure. So we all need to understand that our expenditures well exceed averages for other industrialized countries in the world. Despite this level of spending that we have, other developed nations continue to outpace the United States with respect to key outcome indicators, patient experience, and quality of care. For example, we have a shorter life expectancy, higher prevalence of chronic conditions, more morbid obesity, and more babies dying at a young age. Whether this is a result of behavioral issues that we have in our country or the way we provide care in the United States remains a big question. Research does suggest, however, that some of this excess is likely driven by greater utilization of medical technology and higher prices, as opposed to expenditures on routine visits to the hospital or to the doctor. So one key area of difference between the United States and other developed countries is our view on investments in social determinants of health. And what do I mean by that? Factors such as poverty, food insecurity, behavioral issues, homelessness, and education. Most analyses comparing the United States spending versus other countries don't account for what other countries spend on these social factors, which often exceed what we do in the United States. So developed countries, on average, spend $1.70 on social services for every dollar that they spend on health care. It's the opposite in the United States. We spend just 56 cents for every dollar on health care. Research shows that basic measures of health in countries are more closely and positively correlated with social service spending than with healthcare spending, and I found that to be really surprising. And that's also true when you look at different states in the United States, because we do have variations from state to state on what they spend on social spending. And those states that spend more on social spending do spend less on health care and have better outcomes in areas such as adult obesity, diabetes, lung cancer, asthma, and heart disease. So as we look forward to the future, there are still many unanswered questions about what our healthcare system is going to look like. We know there's going to be shifts in reimbursement coverage between private insurance and Medicare and medical assistance, and that hospital systems are going to transition from volume-based incentives to more value-based care, and I know we're going to talk a little bit about this during the panel discussion. In addition, the introduction of new technologies, new medications, and innovations for which the United States is well known continue to accelerate with the potential to permanently alter the face of healthcare delivery and access. So today we have 4 leading voices in Philadelphia to provide their insights on what potential changes to our system mean for care delivery, for payment, for policy making, and for health advocacy. So let me introduce each one of the panelists, and I know we all thank them for taking time out of their very busy schedules to be with us today. So first, and I'll ask you just to raise your hand so everyone knows who you are, Tony Coletta. Tony is the Executive Vice President and President of Facilitated Healthcare Networks at Independence Blue Cross. He leads the development of Independence Blue Cross's strategic relationships with physicians and health systems, innovative provider contracts, and informatics. Prior to this, he was the CEO of Einstein Health, which is a joint venture between Independence and DaVita Healthcare Partners, providing innovative primary care services. Next to him is Ralph Muller. Ralph is the president and CEO of the University of Pennsylvania Health System, where he has been since 2003. Prior to this, he spent over 15 years as the president and chief executive officer of the University of Chicago Hospitals and Health System. David Nash, who's on our end. David is the founding dean of the Jefferson College of Population Health. He also has spent 25 years as a faculty member at Thomas Jefferson University and is the Dr. Raymond C. and Doris N. Grandin Professor of Health Policy. And last but not least, Allyson Schwartz. Allyson is a former congresswoman Congresswoman and President and CEO of Better Medicare Alliance, which is an organization advocating for strong Medicare Advantage programs through research, policy insights, and grassroots organizing. During her 10 years in Congress, she was appointed to the Ways and Means Committee and served as a senior member of the Budget Committee. Prior to this, she served 14 years on the Pennsylvania State Senate, where she was a driving force behind Pennsylvania's CHIP program. So I want to thank each one of you for joining us again. So let's dive into our discussion about the key topics. So in keeping with Einstein's roots as a Jewish hospital, we're going to start with a Passover Seder theme and focus on 4 questions. And so for authenticity purposes, I think we should have our discussion in Hebrew. Does anyone have a problem with that?
No problem.
Okay. So before we start, I'm going to ask, before we start with our panel discussion, I'm going to ask each of our panelists if they have any remarks that they want to make, and I'm going to start with Tom.
I'll just say, the only thing I would add is my first career was as a general surgeon for 25 years at Bryn Mawr Hospital. So I bring a different perspective. I tell people I'm bringing light to the dark side now. But 25 years in practice, so I've been a provider of care directly at the bedside and in the operating room for patients for a long time. And one of the things we'll talk about today is I'm hoping to bring that same patient-centric perspective to independence, as well as to our partnerships with folks like the University of Pennsylvania.
Well, I'm pleased to be here, so I'm looking forward to the discussion among the panel and so forth. In addition to the roles I played in hospitals, prior to that, Chicago, I also served in Massachusetts with Governor Dukakis, running the state welfare department. So my professional career started kind of dealing with Medicaid and what we used to call the AFDC programs and child welfare programs. So that's how I came into healthcare. And obviously, Governor Dukakis didn't do that well after I left because he ran for president in Macon. But I landed up in Chicago with Mayor Daley, so it's a pleasure to be here with all my friends.
And Philadelphia is the best spot, right? Yes. I would say it's best for last. Well, I think many of you know me, many of you follow my career, and you supported me. So I'll start by just saying thanks so much for that. I suppose a disclaimer, or maybe just credit I actually on the board of Einstein Hospital Health System, so I'm really proud to be doing that. And just really briefly, because we covered a lot of background on where we are in healthcare, I'm happy to add my words and answers to the questions in terms of my experience over a decade in Congress, knowing a lot of the players, the way it works, when it doesn't work. Although this is a rather extraordinary time because we have a very unusual president. I'll put it that way. You know, I will quote him. I don't always quote him. But the president said that healthcare is really complicated. Exactly. Some of us already knew that, but it is really created. I would say the reality, if there's such a thing in Washington, is that there's a lot of fatigue going on in Washington by the stakeholders, the policymakers about how to deal with healthcare. They did try and repeal and replace the ACA more than 50 times while I was still in Congress, and then of course once they were in charge, figuring out how to repeal it and what to replace it with turned out to be far more complicated than they thought. And that has a lot to do with the fact, on the serious side, their goals are not clear. In some cases, they're misaligned, and there really just isn't agreement even within along cross-party lines, certainly within the Republicans, as to what they really want to do, other than knowing they want to repeal the ACA. But how to replace it, it's not clear what they're going to do. Still working on it, we'll talk about that. But I want to tell you that just briefly that the work I'm doing now is really quite interesting. I wanted to keep up and use my understanding of the way Washington worked, my reputation in Washington as someone who knows healthcare, who worked across the aisle to get things done, figured out some common ground, and really pursued a mission. And that's how I got things done, is for me to do that in Washington, really know what you want to do and then go after it. But one of the things I did in Washington, I'm known so much in Pennsylvania for CHIP, but it turns out in Washington I did a lot of work for those of us who are over 65, because what we do in Medicare matters a lot to what we do in healthcare, not only for older adults, but for everyone. It really sets a lot of the ground rules, a lot of the stage for what happens. And with all of the conversation in healthcare right now that doesn't seem to be working, Under all of that noise, there's a lot of important work happening through Medicare and through some of the federal legislation, part of the ACA, that really was driving this movement to move from a fee-for-service system to a value-based system, to move to a capitated system, to one where plans take the risk, but providers do, where hospitals are being told they have to keep people out of the hospital and not work to make sure they're not readmitted after admission, to do more, to take more risk in terms of bundle payments, and also move away from a fee-for-service system. And while there's much to be proud of in our healthcare system, and there is, fee-for-service has really been failing us. It's a system that drives up utilization, that has the wrong incentives, and that was really designed for acute situations, episodes of care, and hospitalizations. It was not designed for a whole lot of people with chronic conditions living a long time. So redirecting and rethinking how we finance healthcare to address the real issues facing particularly older Americans, but certainly those who are poor or are struggling, is really the issue before healthcare providers, healthcare financiers and payers, including the government. But there's a lot of important and exciting work happening. A lot of it is happening under the program that I work on now, which is called Medicare Advantage, which is a third of Medicare beneficiaries, 19 million older Americans and those with disabilities who have chosen, it's a choice, to be in Medicare Advantage. It's a capitated system that changes the incentives to be more patient-centered, to engage in care management, in a long-term understanding of how you work with patients, engaging patients in different ways, and really trying to redesign a delivery system to get healthcare to achieve the goal I always thought we had, which is not only coverage and access, but improved health outcomes while we're containing costs and getting dollars right. So if we can figure that out this afternoon in the next hour or so, and talk to you about how that is actually happening every day across the country, I'm going to give you some hope that we can get there. And it's really, believe it or not, it's just about every day in Washington. So look forward to the conversation.
Hey, good afternoon. It's really a treat to be here, and like Tony, I am celebrating my 30th anniversary as a primary care doctor. My wife and I moved to Philadelphia 37 years ago. We were interns and residents together at the Graduate Hospital, now part of the University of Pennsylvania, of course, just a few blocks from here. I spent 6 years on the faculty at Penn, and in 1990 left to go to Jefferson, and been there ever since, so it's a wonderful place. I hope we'll do a couple of things today. Maybe one is translate all the jargon that you just heard. Because I'm sitting here making notes like the road from volume to value, bundled payment, what is all this? So we will try to translate for you. I think that would be of value. And the second thing I hope we'll be able to do is talk a little bit about our town. I'm very worried about our town. So I want to bring the Washington discussion, where we have Congresswoman Schwartz as an expert, fantastic. I want to bring the conversation to Broad Street, and hopefully we'll have a chance to do that too. So I'm looking forward to the conversation.
Thank you. So I have a series of questions, and I'm going to pose some of them to specific individuals where you have expertise in that area. Other ones will be open to whoever wants to answer them. But David, you set me up perfectly for the first question, which is, what is population health, and why is it a vehicle for moving us towards more value-based care?
Wow, so the $10 I gave her is paying off pretty good. So colleagues, public health, population health, what's the difference? Who cares? Why do we have the country's first College of Population Health at Jefferson? So first, it's always a good idea to thank your boss publicly. So on behalf of Dr. Steve Klasko, who is Dynamo, and wonderful friends of everybody up here, I want to say thank you. 10 years ago, Jefferson University made a major commitment by putting aside resources and people to say that we need a new type of training for leaders who understand everything you just heard. And so the College of Population Health was approved by the board in 2008. We opened the doors in 2009. My esteemed colleague, Dr. Skouflis, is here with me, one of our key associate deans. So what's the difference between public health and population health? So public health is fantastic. With all due respect to Ralph Muller and Dr. Klasko, the public health community has done more to improve the health of this country than all 140 academic medical centers put together. But the public health community misses a few things. What does it cost? Is it safe? And what's the outcome? So the public health community, AIDS reduction, obesity reduction, smoking cessation, wear a seatbelt, wear a bicycle helmet, stop smoking, be skinny, fantastic, super important, Eagles going to the Super Bowl, what could be more important? But population health says all of that's vital, but what does it cost? How are we allocating the resources? Are we delivering it in a safe and effective manner? And can we measure the outcome? So in our day-to-day, that's how we view the difference. Public health is central to the mission of our college, and something that we're very proud of our heritage in. And we think that population health is where the future is going, and we'll have more to say about that later.
Thank you, David. Tony, next question. How are payers and providers preparing for this transition from fee-for-service to value-based care?
So I guess the best way for me to describe that would be to talk about the strategy that Independence is pursuing now over the last 2 years. I took this position in Independence 2 years ago, and the premise of what we're trying to do is sort of sunset the old relationship between payers and providers. Hospitals would say it's the insurance company's fault, and the insurance companies would say, well, it's the doctor's fault, and the doctor's way it's the insurance company's fault. That doesn't really work. That doesn't provide anybody solutions anymore. And so the premise of how we're approaching trying to change the dynamic to move away from just paying for more widgets and moving towards paying for outcomes where patients get better and paying for resources being directed where they should be directed, which is in the primary care arena, is a partnership between Independence and the provider community. The first partnership that we created was actually with the University of Pennsylvania, followed shortly thereafter with Jefferson. Those two systems, by the way, represent $2.2 billion of Independence's spend every year in healthcare. We spend about $7 billion in healthcare in these 5 counties, $7 billion every year. And these two systems represent $2.2 billion of annual spend. So we've approached it by turning to the systems and say, look, we're not going to solve this as a health plan, I can tell you that. Doctors alone can't solve it. The hospitals alone can't solve it. We need to create a partnership, something new and different. We need to start to trust one another. We need to get to know one another. And we need to think of, and there are three pillars to our approach. It's called the Facilitated Health Networks. The first is by a new and different contract. Gradually sunsetting the emphasis on paying for fee-for-service, so changing the way we pay for things, and increasing the emphasis on paying for outcomes of populations. So University of Pennsylvania manages, say, an attributed population of, say, 100,000 people in a certain venue. They look at that population, and together we figure out how to provide resources for the sickest of the sick, keep people out of the hospital together with these agreements. Less emphasis on the economics of fee-for-service and more on paying for higher quality, lower cost type of care. The second piece is data exchange. So creating an environment where between the University of Pennsylvania and Independence Blue Cross, we take our claims database, which is very rich, and we share it bidirectionally with the University of Pennsylvania's clinical database. That's never really been done before, right? So that data around patients gives a 360-degree view of the individual patient and of populations where we can begin to more smartly direct resources together. So that's the second component. And the third is care coordination. One of the things I found when I started at Independence is managed care has kind of become the insurance company trying to manage your care. So the doctors and the health systems are over here, and insurance company is trying to actually manage your care, mostly through the telephone. So I'd like to see that model sunset, and as much as we can, push the care coordination and the management of the care back to the provider community where it belongs and support them there. So those are the three pillars of how we're trying to drive this change from conventional fee-for-service to a more value-based environment.
My next question is for Ralph Muller. Ralph, how do you, as a provider, balance this move towards value-based care with still needing the revenue generated by fee-for-service, still needing to fill your beds, and certainly you have an academic mission to fulfill as well?
Well, the fee-for-service movement is still alive and well in Philadelphia, and changing these to value-based has obviously been a big push. For example, the Affordable Care Act, also known as Obamacare, and a lot of initiatives have been tried both at Penn and our colleagues in this area. But for example, we're a big system. We employ thousands of doctors, but 65% of the medical groups in this country are still 4 doctors or less. Not 65% of doctors, but 65%. So most of medicine in this country, and this is something that Tony and David and Allyson will do with it, is still a cottage industry. So I think places that are large like Penn and Jefferson and others and independents can make these kind of changes. But when one tries to change the whole healthcare system, one of the challenges is not just the big places, but how you change the small places as well. A place like us, we have 4 hospitals just very close to here, and Pennsylvania Hospital, the nation's first, is about 6 blocks east of here. The old graduate hospital where David trained that we now own is called Penn Medicine Rittenhouse, which is 6 blocks the other way, and we have and Presbyterian hospitals in West Philadelphia. But we're pushing 60% outpatient care now, so not just in terms of volume, but in terms of dollars. So we're a big outpatient system. While we're known for our hospitals, and we're proud of those hospitals, and they're nationally known and ranked, increasingly we cover the 90 miles going west to Lancaster, and we go 90 miles east to the Jersey Shore. We go to traditional hospitals available for the kind of services that only we can provide, but we have moved to the outpatient direction as well to try to make it more and more easy for patients to see us, whether it's downtown here in Philadelphia or out in Blue Ridge or across the 2 bridges to New Jersey and so on. Let me just comment on one of the things that was said in the introduction about how much money our society spends on medicine. And we do spend more than other countries. I was trained as a social scientist, not as a doctor, so my professional background once upon a time, and then running a law department, was now the jargon is the social economic conditions of health. This country likes to medicalize conditions that probably could be better dealt with by teachers and social workers and community workers. And I'm in favor of doing more and more in those settings, but we tend to ask doctors and nurses and others to take care of conditions that could be better treated in other settings. People present at our emergency rooms every day. We see hundreds of thousands of people in our emergency room every year, and many of them come in with conditions that you wish would be treated elsewhere. To say you'd like to treat them elsewhere and making that happen are 2 different things. And I think one of the challenges we talk about today is how you move more of those kind of needs of patients to community settings, and working with payers like Blue Cross and Medicare, which is the biggest, one of the biggest insurers in the country, as well as Medicaid, to move in that direction is of great importance. The other thing I would note is, in between my time in Chicago and here in Philadelphia, I spent a little time over in the UK. And they have a different system of healthcare over there. And I wrote about it when I came back, and I said, the British system is committed to fairness. The U.S. system, going back to our Constitution, is committed to liberty. We like choice. And the health systems of a country reflect the political and cultural values of the country. And insofar as one is concerned about some of the costs in the medical system, one has to really deal with the underlying political and cultural values, which don't change that quickly. So sometimes when we say we spend too much money on medicine, we do so in part because people want access to medicine in proportion that other countries provide more social and other kind of community services. If you go to the UK, or the Netherlands, or Germany, or France, you see much more spending on social services. And if we had more of that, then perhaps less we spend on medicine. But that's not happening anytime soon. And I could easily argue that wealthy societies like ours are going to spend more and more on medicine. Doesn't mean we should spend very appropriate services. Doesn't mean we shouldn't go more toward value. But I fully expect that, just like other countries, that curve will keep going up in this country because people want access to medical care. So try to put a few issues out there in terms of that this is much more a function, not just of what doctors and hospitals do, but the overall cultural values that one has in a society. And insofar as we as citizens want to limit choice, which is, I was around, like the rest of you, 8 years ago with Sarah Palin and her death panels, and the kind of political rhetoric that goes around about limiting choice. One of the challenges in society really is to put more limits on choice, and by and large, we're not very good at that. We're much more into creating red tape as a way of limiting medical progress.
This question is for any of you actually. What kinds of integration or consolidation or partnership activities are you seeing that are improving the healthcare system in the United States, be either local or national?
I'll start on this one. And some interesting comments, right? We would have some interesting conversations. We're all sitting in a room as to what is it we want out of healthcare. You know, it's not an easy conversation to have. And I think most of us say we want everything, right? That's what we want. We want it all. We want the most high tech. We want the most you can do for us. We want all the fancy stuff on the machineries and the medications and technologies. But I think we would also say, and this is the way I would say it, is we've also got to be smarter about the way we provide the care, and we've got to concentrate sooner in the process of getting sick. Okay, so, you know, or prevent that from happening. And we think of prevention as getting a vaccine, or, you know, getting your flu vaccine. You should, if you're in the right category, and that would help. But it is also about reorganizing, because we sort of forget about that. And I think in Philadelphia, because we have such fantastic academic institutions, sort of have, you belittle the notion of a primary care. We all think it's a good idea, but really, who stands up and gives the award to the primary care provider? Maybe Jefferson does. But who, you know, or who says, you know, I really love my nurse practitioner, and it's really okay for me not to see the doctor every time because my condition doesn't change that much, and I need some help in really doing what I'm supposed to be doing, eating right, taking my medication, going to see the clinician when I need to. Those things sound so small, but it turns out they matter a whole lot to improving the health status and saving dollars. And it's really smarter. So I would, for one, say, I want you to keep doing much of the sort of really elaborate, fancy, specialized care, but we've got to do better at the primary care and at dealing with these social determinants. And I'm a trained social worker. That was a long time ago, but I learned a lot about social policy. So I agree. Did we not notice that poverty might get in the way of good health? How ridiculous. Of course we know that, but we haven't acted on it in the right ways. You know, increasingly, we live in Philadelphia. I remember when I first started out in healthcare, we were really worried about Medicaid mills. Did you ever hear that terminology? Ralph certainly did. Dave did too. We don't even have those anymore. There aren't even doctors in most of our poor neighborhoods. So when people show up, get sick, if you're poor, if you're lucky, you know there's a federally qualified health center or a city health center nearby, and you've made some relationship there. But by and large, you're going to end up in the emergency room. And if they don't know you, they don't have your medical records, they can't get them at that right moment, they don't know anything about you, they're gonna, and you have something serious. If you don't have something serious, you'll be there for hours and sent home. But if you have anything that's questionable, you're gonna end up being admitted to the hospital, have lots of tests, and some of those may be necessary, and maybe some of them are not, and even the ER doctors in the hospital know it. But what are you supposed to do, send that person home? It's happening over and over again. The point I would make, and I think some of us are making, is why don't we get that part right? Why don't we help make sure that there is a health center or a doctor or a nurse practitioner in those settings that can actually help change the healthcare providers system? And some of this comes with what we pay for. Providers have to pay for this, you know. But how do we also help patients and engage patients where they are? So the question on community partnerships and what are the partnerships? One of the great things about the work I do is we say healthcare and Medicare Advantage is not just about the doctors and the hospital system for the payers. We think that it is also about community partners. Some of our ally organizations are the YMCA, with their exercise classes. You may have heard of Silver Sneakers. Well, I think it's a great name because it's really about people who've never exercised, not going to a gym, can't imagine showing up at LA Fitness, who can go somewhere where there'll be other 70-year-olds trying to walk on the treadmill, or other 80-year-olds figuring out how to get better balance because they know that they're walking slower and really uncertain, and there's a huge risk of falling. So there are things that we can do, and that's what we're doing. So the YMCA, Meals on Wheels, David mentioned food insecurity. Meals on Wheels did a program actually with Humana a few years ago that said they were going to deliver 10 frozen meals to frail elderly living alone who had just left the hospital. Now, I'm sure I went to the hospital when they discharged. Somebody thinks about, is this person able to actually feed themselves for the next 10 days or 2 weeks or a month? Now, increasingly, they are thinking about those things. But it turns out to reduce readmission rates for that cohort of people. It was something like 30%. It wasn't small. It wasn't like 3% or 2%. Like, should we bother with this? It was enormous. These were people who didn't get to eat right. No one was looking in on them. When they had a question, they didn't know who to call, or thought they wouldn't bother their doctor or the hospital. And they actually got the right kind of care. Some of that was just simply being able to have somebody make sure they were okay and give them some food to eat. This is not expensive work, and maybe Ralph's right, it's really not the job of the healthcare system, but it's got to be someone's job, because we're spending a whole lot of money that could be spent in different ways and reduce the cost of healthcare over time. That's what we should be driving. That's what value-based care is. The conversation about that's the point I'll make, is who's high risk? Is it, how do we define that? The idea of data sharing is huge. We actually know who these people are. So instead of waiting for them to show up at the ER or a hospital really sick, we can go out and talk to them and get them what they need and encourage them to come into the healthcare system and to engage and take some of their own personal responsibility in meeting halfway. It's sort of exciting stuff, actually. You start thinking about what could be done that would put less of a burden on a very sophisticated healthcare system.
Thank you, Allyson. Tony, did you want to say something?
The only thing I'd say about partnerships in this new world that work, there are not a ton of them just yet because it's so new. And everything that Allyson said and everyone else is saying is wonderful and really makes sense. Really difficult to scale up. Really difficult to scale up, especially if you don't have the right business model in place. One of the things we have started as a disruptive entity in Philadelphia, we mentioned Einstein Health. I was the CEO of that. It's a purely primary care driven company, 455 primary care physicians in a network in the 5 counties in Philadelphia, managing 115,000 independence patients. That's our population. So applying population health to that population. 35,000 Medicare Advantage patients. The rest are commercial HMO IBC patients. And partnering with these physicians to put the right economic model in place to incent them for the right type of care, providing them the data and information that they need so that they can find out who are their highest risk patients, and then providing the additional care resources to get more resources to those patients. The only other thing I'll say is we're also begun a house call program. I don't know if most people have heard about this yet. In the Philadelphia region, both Independence and Tandine now have a workforce of doctors and nurse practitioners who are going into the homes of the highest risk, most vulnerable, mostly Medicare Advantage patients on commercial in the 5 counties. And about 2 months ago, I went out and I do this regularly to get close to the point of care and went out with a house call doctor and made 2 visits with that doctor. She was really amazing. And when you see upfront and personal the socioeconomic challenges of these chronically ill Medicare Advantage patients in difficult situations, non-supportive families, living alone, they seem to be extraordinary problems.
And incentive experiments, and you heard all the jargon about value-based payment and all the rest, but its central core goal was to cover more people, create access. Why is that important? We have irrefutable evidence. If you have access, your health will improve. So it was a population-based improvement model, not designed to cut costs. It's piecemeal. It was compromise. It robbed Peter to pay Paul, but it did deliver on its central goal to create an improvement in access, and not much more than that.
Let me challenge that. it did cut costs, and what government knows how to do better than anybody else do, just cut rates. And government knows how to do it, and they did so. So, for example, as David said, the very commendable accomplishment of the Affordable Care Act, it brought over 20 million people into care, into access to care. in the 6 years since it's been implemented. It's also part of the agreement that doctors, hospitals, and others made at the time that Obamacare was passed. And President Obama calls Obamacare, we can all call it that too, was to really reduce the level of payments to doctors, hospitals, and so forth, and that has worked. For example, the rate of medical cost inflation since Obamacare was passed, implemented in 2011 to now, up to the more recent spike the last year or so in larger pharmaceutical prices, and even the current president is speaking about that, had gone to about 5% a year, the healthcare cost. Now this is, in the era going up to that, and the Affordable Care Act was meant to have the kind of double meaning of both having access to care, in that sense affordable to people, and affordable in terms of bringing the costs down. The rate of payments to hospitals and doctors went down from 2011 to 2017. And I would still argue, even with all the innovative models in the Affordable Care Act, the effect of those rate cuts was very profound and brought down the rate of medical cost inflation. Now, some people might say, running at 5% a year over the last 6-7 years, it spiked a little bit more in the last year because of the pharmaceutical prices, is not that great when overall cost inflation in the rest of society is 2-3%. But prior to that, it was going up about 8, 9, 10% in the prior 10 years. So I would say it did have a damping effect on the cost curve. It still has not had as much of an effect as the people who were the architects of it would like to have had. But those payment cuts were there. Some of you may have read, there's an article, front page New York Times last week, about this hospital in a small area in Arkansas. And they made the point that since the Arkansas Medicaid expansion was not as generous as it was in some of the northern blue states, including Pennsylvania, not as many people came on to Medicaid in that small region so their Medicaid expansion in dollar terms was not as much of an add-on to them as the Medicare payment cuts were to them. In most other parts of the country, including Pennsylvania, the Medicaid add-ons for us were beneficial to us as doctors and hospitals, where we were economically rewarded. At the same time, the patients were rewarded more so than the payment cuts. But that just shows you, in states that did not do the same kind of Medicaid expansion that Pennsylvania did, that issue was reversed.
I mean, I'll just add a couple of things since I sat in the room for hundreds of hours working on this. No question, the goal was to actually get coverage for Americans. And the decision was made as to be not be disruptive to those who had coverage. I'll be careful how I say this, but basically people who are employed would continue to get coverage through employment. And that's how most people in this country have health insurance coverage. So really the goal was then to figure out those who were uninsured, and typically uninsured, which is young people and early retirees, and people who are poor and in a job and simply can't afford health coverage. And the ACA tackled all those groups and said, we're going to pay subsidies for incomes higher than you might even imagine, but even at $50,000, $60,000, $70,000 a year, $80,000 if you went up to, it's really hard to find $12,000 after taxes to pay for health coverage. So you couldn't, even if you wanted to. So that's what the subsidies are all about. That's how about half of those, 20 million got covered. The other half are pretty deeply poor but not eligible for Medicaid. And that's the other half of the 10 million by expansion of Medicaid. More would have been covered if more states picked it up on it. It became a state option after the Supreme Court decision, so not every state picked up on it. Pennsylvania, I think, is about 600,000 people are on the exchanges in the individual market. That's the toughest market. I think even a representative from the Blues would say they have a responsibility to have an individual market, and because of the way they're set up. But they've always been a difficult population because they do come in and out of coverage. They're not very stable in a way, sort of economically, so it's challenging to cover them. And it turns out, I think we didn't really understand how sick they were as well, and ended up being more expensive. So it was a very big and complicated law, and just as Medicare, when it was first enacted, a lot of people didn't like Medicare when it was first enacted 50 years ago, and also a lot of changes have been made over time to address some of the things that didn't work exactly like they anticipated. That's not a big surprise. As a lawmaker, I can say, you know, you get something done, you hope it's perfect, but it isn't always. And so you have to go back and say, maybe we have to fix this, maybe we have to fix that. And obviously some of the issues around the individual market, and that's what the big discussion obviously in Washington is right now about can they you know, shoring up the market. And the way it was done originally was to have something called reinsurance. So in case these people were a lot sicker than anybody anticipated, no single payer, no single insurer would get hurt, particularly if it wasn't distributed well, and a few other issues there in terms of the subsidies. So a lot of conversations in Washington, should we still pay the subsidies or not for these people who actually make too much money for Medicaid but can't afford health insurance, or do we want them to go back to being uncovered? The other big question in Washington is, should we establish the essential benefits so that when you buy insurance, it actually covers what you sort of thought it was going to cover most of the time, or should we allow for more catastrophic insurance? Don't pay the doctor's bills, don't pay the routine primary care, don't pay obviously for family planning, but you know, really, and just save it for that trip to the hospital that would really bankrupt you. And there's a point to be made to have an argument, should we allow more catastrophic coverage or not? And in the meantime, hospitals and doctors, you know, have to still provide all this care. So readjusting to that, readjusting to people getting coverage. But the fact is that we've reached enormously high levels of insurance coverage and are just beginning to see some of the, I think, positive consequences of what were built in, maybe more quietly, to the bill about how do you beef up primary care, how do you encourage a capitated system, how do you actually drive some population health movement that was built in there. But that, as you've heard, it's not easy to change doctors and health systems overnight. It takes real time. You know, some of the things you've heard today, even the idea that insurers sharing their information about who's really sick because they have the claims data with the hospital system that doesn't have that is a big deal. Because then there are names and addresses and phone numbers and maybe even emails that you can actually say, wait a minute, those are patients we see in the hospital a lot. But now we actually know really who they are. Because in Philadelphia, because there's so many hospitals, they could be at Hub one day and at Jefferson the next month.
If they're smart.
Oh, I got myself, yeah.
David looked like he wanted to.
So I'll let David take over here. But there's lots of interesting stuff going on. It's not immediate. It takes time. It takes change. It takes a willingness to change.
Yeah, so I'm just amazed we're even having this conversation. Who's covered, who isn't? If someone came from any other Western civilized nation on this planet and listened to this conversation, they would be aghast. So that's the core issue. It's not who made less and who made more, and that's not it at all. So let's talk about this town, okay? Let's get it down to Broad Street, because that's why I'm here. So Tony and Ralph know this, and maybe you do too. So in this city, 1/4 of everybody who lives in this town lives in poverty. Half of them live in deep poverty. That's Uncle Sam's code word for you can't put food on the table. You remember when the Pope came to Philadelphia? Jefferson was his select hospital, wisely. Schools were closed for 2 days. As a result, thousands of students in this town had nothing to eat for 2 days. We took hospital food to feed those children. So 1 out of 4 people live in poverty in our city. Number 2, we have the largest income disparity and largest disparity in lifespan of any of the nation's top 10 cities. Of the nation's top 10 cities, we're the poorest on a per capita basis. Poverty is the central driver of poor health, only in the United States of America. So that's the conversation we should be having, not who made more, who made less, the bill, the intricacies, the trade-offs. That's not the core issue. 1 out of 4 people smoke cigarettes in this town. National average, half of that. 1/3 of all the public school students in this city, walking distance from where we're sitting, are obese. So for the adult doctors in the room, like me, they're going to grow up and have all the challenges and problems. So the primary care problem that you brought up, well, so in Western Europe, it's 3 primary care doctors to every specialist. In this town, due to Penn and Jefferson, it's 4 specialists to every primary care doctor. So Allyson is right, it's not an overnight fix, but let's get real. The core issues have very little to do with Blue Cross, Jefferson, Penn. The core issue in this city in particular is poverty and income disparity. And that's what drives the ill health of the population. That's the core issue.
So I'm going to piggyback on that and ask Ralph or Tony, what do you see your great organization's roles in tackling some of the issues that David talked about? What are you doing?
So, you know, I mean, how do you correct this type of problem in one of the largest inner city problems in the United States? You just are not going to tackle that problem overnight. The thing that's, and I understand and appreciate the statistics that David is sharing, but in the meantime, tens of millions, probably hundreds of millions of dollars are either being wasted or being used inefficiently in our current system. And systems are aggregating into large. Jefferson has acquired how many hospitals and how many more specialists in the last year and a half. All that is because of the fact that this is healthcare is a big economic industry. It's a big economic engine in the Philadelphia region. The largest employers in the region are hospitals and health systems. So having said that, I think what we need to do first is get the basics things right. We're not going to be able to tackle poverty while at the same time we can't even identify in our own populations of patients or panels of doctors who the diabetics are that need the most care. Who are the ones that missed their care last year that are going to get sick next year if they don't get the care they need. The whole principle behind a partnership with the health system is to create the type of information and economic incentives necessary to ensure that the health system and the patients benefit from directing resources to where we know they're not being directed now. We live and work in a highly fragmented healthcare industry. Many of you probably have had unfortunate interfaces with it. I've lived and breathed it for 25 years in the operating room at Bryn Mawr, where the patient was in the midst and oftentimes got lost in the shuffle of being in one place or another, one doctor or another. You're in the hospital with certain medications, you leave the hospital with different medications. They're not the same medications. You go home, it's a constant onslaught of highly fragmented care. And while at the same time the socio-economic issues that the city faces are very, very real, I think we have an obligation immediately to do all we can to correct those basic problems of delivery of care, and that's what we're trying to do. Again, it's just a year or two into this new effort, but you've got to move towards what you know the right thing is to do, which is to find a way to lower the cost and improve the quality and defragment some of the care, which we're all responsible for.
Well, we focus a lot on what you can do right now until society changes. So, for example, we have what's called a common electronic record. Only we in Children's Hospital know the system in this area has it except us. We, no matter where you go, hospital, emergency room, doctor's office, home care, come in by telemedicine, you're in a common record. We're the only one who has that. It allows us to really be in touch with our patients everywhere. We have, for example, we've hired in the last 4 or 5 years 50 community health workers that are up in the neighborhood, and they go out to the homes where, as Tony referenced earlier, you do home visits and you see that patients may not have their medications refrigerated, they may not be able to afford their medications, they may have loose rugs that they trip over and come back to the emergency room. They may have some child who has issues with substance abuse and so forth. So we have 50 workers that we pay for ourselves, nobody else pays us for it, that we send to the community to help patients with these kind of issues, so they don't wind up in the emergency room, they don't wind up in hospitals. So we've tried hard, and some of these payment arrangements that we have with Blue Cross and other big insurers like Medicare, we now take responsibility for people over 30 days, 90 days, So we in a sense, I've written about this, we hover with them and try to deal with the issues that they have. So it's not just the hospitalization, but what happens after they leave the hospital, and sometimes even before they come to the hospital. I've mentioned earlier, most of our activity now, we see over 5 million people a year in outpatient care. So having outpatient care everywhere, having common electronic records everywhere, having telemedicine everywhere is part of what we've really been innovative. But the kind of issues that David raised about, we may all want that, but as President Obama said, elections have consequences, and the person who picked last year is not moving in the direction that they want them to move in. So I think we have to deal with the system and take the opportunities we can right now to modify the healthcare system. And part of what we're proud to have partnership with Blue Cross, but also with Medicare. We're taking the steps right now to try to modify some of these ills that we have out there. At the same time, we're not a society. We're not Denmark. We're not Vermont. We're not 700,000 people. We're not a homogenous society. This is a very diverse society. And getting political consensus on these things just is very hard to achieve in this country. So what we try to do is focus on the issue at hand, which is the people who live within 100 miles of us and what can we do to improve their lives every day. And then, like you, I go vote for people who may want to do something different than the current president does, but at the moment, this political system is not changing very quickly in the direction that David suggests.
Thank you. So we have about 5 more minutes. I'm just going to ask a few more questions, and then we will move on to our question and answer segment. So let's take our crystal ball out and look down the road 5 to 10 years. Tony, this might be a good question for you. What do you see happening with healthcare costs, out-of-pocket costs, premiums?
Well, hopefully first in 5 or 10 years, I'll be like on a boat fishing somewhere. So I think in a dream world...
And you'll be paying more out of pocket in those 10 years.
And I do think in sort of in a dream world, if we look out 10 years from now, the way I think is what I would describe as you need to be thinking exponentially. We're living in an exponential world, and you are not going to fix these problems if you think in a linear fashion. So let me try and explain what I mean by that. If you're thinking about curing the problem of healthcare, and you're thinking about primary care being the resource that needs to be maximized to ensure that we're using data and information to prevent illness over time, the typical argument would be there's not enough primary care doctors in the United States because one primary care doctor takes 2,000 patients, two primary care doctors have 4,000 patients, 3 primary care doctors have 6,000. That's linear thinking. This is an exponential world. We've aggregated more data in the last 2 years than the entire history of mankind. We need to start thinking exponentially because you're talking into your phone and you're seeing the artificial intelligence become a new user interface. We need to be thinking about solving this problem exponentially. If you think exponentially, 10 years from now, one primary care doctor and his or her team could take care of 10,000 patients. If you have aggregated data that shows who are the patients that need the most care at the right time, and you use the evolving data and the integration of that data as part of the delivery system, 10 years from now, I would expect that we'd be in a position where the system has been, at least in the beginning, transformed by this exponential thinking. We'll have teams of people taking care of populations of people, and the data and integration and the growth of things like artificial intelligence will simply empower that. I mean, I don't know if that's specific enough or not. I don't know if premiums are going to go up now. I don't even know if premiums are going up next year, let alone 10 years from now, at least in the Obamacare world. So.
I'll be brief. The forces of inequality are just going to get worse in the next couple of years. The tax cut coming, that's going to be, probably everybody in this room would be advantaged by the tax cut they're discussing, but it's a bad tax cut. So before we all think this is all getting into more equality, I'm worried we're going to have more inequality in the country in the next couple of years. So I think people of means are going to have access to good health care. And as David and other people said, people of less means are going to continue to struggle. And obviously there's 19 states that didn't expand Medicaid. That's a total no-brainer to expand Medicaid. The fact that 19 states, including 2 of the highest population states, Texas and Florida, did not expand Medicaid is a crime. Should have happened, didn't happen, and so therefore I'm glad Pennsylvania and New Jersey did. But those things are not changing anytime soon. In fact, a lot of the states want to go in the reverse direction. I think the most profound technology that's going to affect our world in the next few years in healthcare is right here, the smartphone. I think, patients, some of my colleagues at Penn have done work that tells us that 90 days after you buy your Fitbit and so forth, to stop using it. But people carry the smartphone every day, and they're going to keep using it. So I think the ability to stay in touch with patients, to give them suggestions as to what to do. Now, changing, underlying, substance abuse often comes from addiction. People who don't have income, as people have said in this panel, are not going to get income overnight. But the ability to use this phone to constantly stay in touch with people, I think is going to have profound effects on healthcare costs and behavior. When you can do images off this, for example, one of the things that Tony and I work at the Blue Cross and Penn is if you have images that you send to your dermatologist, why travel all the way down to Penn from Allentown or wherever? You just scan it and send it in, and obviously Tony has to worry about it. In a generation that texts 200 times a day, you don't want them to start doing images 200 times a day. But so they have to worry about things like that. People with Parkinson's disease, for example, I'm sure some people have had, or other kind of cognitive disorders, we now do a lot of telemedicine as well. Increasingly that will be done with smartphones. So I think in terms of technology disruption, the next 10 years, the most profound effect is going to come from the increased use of the smartphone in healthcare. And plus, as you notice, Apple, Google, all those big companies are going to get more and more into healthcare than they have. They see that 17% of the economies in healthcare, they're coming as well. So my two big predictions: don't count on income inequality going down in the next 10 years, but not obviously politically think that's a bad thing. I wish it would go in that direction. But with this administration, they're not changing. And second is watch the technology comes out of smartphones.
At this point, we're going to move on to some of the questions from the audience, and I have 5 of them in front of me, and I'm going to direct them to particular people, but if someone else wants to answer them, that's fine too. Allyson, first question: what will happen to the folks covered by CHIP if it ends in February? What do you see happen? I know how near and dear this is to your heart.
Yeah, I think CHIP gets reauthorized and we'll be fine. How's that? Actually, I think CHIP will be fine. There's really strong bipartisan support for CHIP, and there's interest in making sure it continues. And this is obviously coverage for children who families that make too much money to be on Medicaid. They're really working families who may be covered as an adult, but maybe their kids aren't covered or they don't have health insurance. So I think it gets reauthorized, which means that it would go away if it didn't. I think states are figuring on that. I would say if it doesn't happen by the end of the year, we're in trouble, but I do think it happens. The big issue of why it hasn't happened yet is because you have to pay for it. And there's a real disagreement about how you pay for it. So where the money comes from, and they're working on it. So next week there's going to be a vote in the House, but it's not easy. Nothing's easy right now. Ralph's become the politician on this panel, which is good. I'll leave it to him. I think he was right about where we're going. But I think CHIP has really been so widely supported and understood as a good thing, which maybe comes a bit from what they think. We actually think covering kids is a reasonable thing to do. I think we should be proud of Pennsylvania that we were one of the first states to do it 5 years before the federal government did. But it's huge. It's 9 million kids who are covered now by CHIP. And I've young adults coming up to me all the time saying, "Thank you so much, I was a CHIP kid." And what's interesting about it is that they're proud of it. They didn't see it as welfare, they didn't see it as a handout, they thought it was, they knew their mom or dad couldn't pay for health coverage and they felt good about it. And that's the way we should be feeling about our health care coverage, that everyone should have access and it should be easier, simpler, more seamless than it is now. And that's why I hope for these CHIP kids who are now adults, that it is for them.
Thank you, Allyson. David, my next question from the audience is, what country or state has the best model?
It's a great question and no easy answer. And I agree with Ralph, we are a very heterogeneous country, so the best model, there is no single best model for us. I think we have to agree on what are the basic things. I mean, another part of the conversation we haven't had is, Allyson sort of alluded to it, but let's translate it. The country has not come to a conclusion that basic access to health care is a right. So until you have that conversation, you can't deal with all these other issues. And many state governors, by not accepting Medicaid expansion, made a decision that health care in their state is not a right. So there is no single best model. There's aspects that make sense from all over the world, which we have a 14-week course on trying to sort this out. But I think that the core question is, we haven't had the key conversation, is this a right, or is this something that